Hey guys, welcome back to my channel. Today's video is going to be on golden hour and extreme prematurity. If you guys are interested, let's get into the nitty-gritty. So depending on the hospital that you're going to work at, if you're going to be NICU specific, if it's a delivering hospital, there's going to be a chance that you're going to experience a golden hour admission. Golden hour means it's any babies that are born at a gestational age less than 32 weeks. Or 32 weeks and less. So the admission bed would be a little different than if it was 32 and 1 and plus. So if it's term or late preterm, it would be a little different. So first things first, let's get into the setup. The setup for a golden hour admission, it's going to be different in a sense that if it's in the OR or if it's in a labor and delivery room. So if it's a vaginal delivery, it may look a little different. It depends on your hospital, like I said. So what you want to do is have either a radiant warmer or an isolette. In the case in my hospital, we usually bring an isolette to the delivery, and you want to have it warm to 100%. You want to make sure that the bed is hot, because the thing is with extreme prematurity patients, they go hypothermic very quickly. If you remember from nursing school, we experienced when we got to the OB rotation, the OB, peds, that kind of thing, you would go over convection, conduction, radiation, how heat loss can be prevented. For these babies, we want to make sure that we have a plastic bag. That way we can put the baby in the bag, and the moisture that's on their body, they have limited amounts of, they can stay inside the bag and they don't lose it to the environment. And then you also, not only having the warmer set up to 100, you want to have a transwarmer mattress underneath. Those are the ones that have a chemical snap in the bottom, and then they get hot, kind of like a heat pack, an instant heat pack, or like the reverse of an instant cool pack, if that makes sense. That's trying to cover hypothermia. We want to prevent hypothermia in these extreme prematurity patients, because what ends up happening is cold stress, and that is no good for any baby, but these babies, it's much worse. What we do want to also incorporate for them is humidity. After we're done with the admission and we've closed up the isolette and we keep it kind of like a little incubator setup, you want to put some sterile water in the isolette and give them about 80% humidity. Because that's normally how much moisture there would be on their skin if they were still inside. And that helps prevent hypothermia and heat loss, excessive heat loss and water loss. So another thing you want for your bed is something to monitor your vitals. You want to have your pulse oximeter, your ECG leads, you want to have your blood pressure cuff, you want to have your thermometer, measuring tape, a diaper on hand, and I think that's pretty much it. Just anything that you need to make sure that you get the vital signs for these patients. Next up, in terms of, so we covered hypothermia prevention and vital sign monitoring. You want to get stuff for respiratory. So most of these patients have their respiratory depressed. So you want to have things to resuscitate. You want to have a bag mask, like an ambu bag. You want to have maybe a neopuff that gives a certain amount of PEEP. You can also get an intubation box, so you can get an ET tube in the patient in the delivery room. And then you also want to have a CO2 detector in the event that you do have to intubate, to make sure that you're in place. You want to have oxygen tanks. Those should be on your isolette before and checked before you get to the delivery. You want to make sure you have your tanks full, so that you can get the baby from the delivery room to their NICU bed, and that way they always have oxygen on them. And you want to check also that there is an oxygen setup in the room, so that way you don't have to be on the tanks right away. You can be set up to the wall oxygen, but you need a blender. You want to make sure that you're not giving them too much oxygen, because that's going to prevent retinopathy of prematurity for their eyes. You want to start between 21 to 30%, and then in the event that they need more oxygen, then you adjust the FiO2 accordingly, but you don't want to start off at 100% and blow out those eyes. So now that we have everything set up for the golden hour admission, the baby has been delivered, we've done our NRP. NRP is a neonatal resuscitation program. It's like CPR, but for neonates, because we have to tailor it a little differently than if it was just a baby for NRP. And to be in a NICU, you have to be certified in NRP in order to have that job. And then, so we've set up the bed, everything's ready. We've done our NRP, our baby is resuscitated. We've gotten the baby to the NICU bed. Now, what we call golden hour is the critical hour, which from the time of birth to 1 hour of life, you want to make sure you complete a certain amount of tasks. Golden hour is kind of like a PI project where it's improving extreme prematurity patients' outcomes. It's not necessarily something that is practiced in every hospital or that it's deemed golden hour. It's just something that we've been calling golden hour in my hospital and several other hospitals around as well. So golden hour, it's supposed to reduce hypothermia, reduce hypoglycemia, reduce brain bleeds. It's supposed to also reduce chronic lung disease or BPD, bronchopulmonary dysplasia, and like I said, retinopathy of prematurity. It's not necessarily practiced in all hospitals, but most places do complete these tasks in a certain time frame. Golden hour is just kind of like something that most hospitals aim for. So what happens in this hour? So you want to make sure that you've started fluids for these babies. You want to get them with central lines, a chest x-ray, antibiotics. You want to have their labs sent. You want to make sure you have a normal temperature. You want to give them the erythromycin and vitamin K, which is normally given for all babies within the first hour of life. And IV glucose administration. That is major. Seems like a lot, but if you have a structure or there's like a checklist that you can follow that makes sure that you're on top of it. But if you've done many golden hour admissions, it kind of happens naturally where you've set up for lines, you've done everything like that. So that way it's more streamlined and then the patient's outcomes are improved because you're more prepared. One thing I failed to mention was if you've done your neonatal resuscitation program, your NRP, and the baby is crashing. Let's say it's an emergency delivery and the baby is down and need a crash cart. So you're gonna call either a code, depending on your hospital. In mine it's code pink. You're gonna call a code, that way they can bring you a crash cart. You wanna make sure that ahead of time before this admission that you have at least a code sheet. So this code sheet goes based on the baby's weight. Most of the time the OB can give you an estimated weight for the baby before they're born. Otherwise, there's usually on the crash carts kind of guidelines for gestational age and weights. It depends on your hospital. That may not be available in every place, but you want to make sure that you get that baby's weight ASAP. Before you've put more things on the baby, you want to get their weight because that's their dry weight that they are when they're born, and that's where you're going to get your dosing for all of your meds, your IV fluids, and everything like that. So you want to get a baby weight right away, a head and length, abdomen and chest as well measurement, and you want to get all 4 extremity blood pressures. That way you can determine whether the baby needs fluid resuscitation as well. Most babies do have a shortage of fluid when they're this small. So if you do a blood pressure and the mean is less than the baby's gestation, you want to try to either find a way to get them a fluid bolus or maybe they're short on blood. It all depends on what the neonates necessarily need at that moment. It could be that the mom was bleeding out, so you never know what sort of fluid resuscitation the baby can require. You want to make sure you get that baby on a monitor ASAP. You want to know the baby's saturation and then their heart rate. The heart rate really dictates what NRP's guidelines go by. We go by if the baby has a heart rate of 100, the baby has a heart rate of 60, there's an algorithm that you have to follow. You even start chest compressions for babies with the heart rate less than 60. So that's why it's important for you to have them on a monitor ASAP. You can always check an umbilical pulse just to make sure that you have the right an accurate pulse in the time being that you're getting the leads on. A lot of times these babies are moist and very sticky, so these the monitors that you put on may not stay, but try to find the best way that you can get them to be on a monitor ASAP. You also want to make sure their nose and mouth is patent. Usually we do suction with either the wall suction or a bulb syringe, just to make sure that their nares are patent if you're going to keep them on some sort of nasal CPAP or NIPPV. But if they're intubated, you want to make sure that their oral airway is patent. You never know, it could be a baby with a TE fistula and things could be a little different in their anatomy. So you just want to make sure that they have some sort of patency in their respiratory tract. OR temperature or delivery room temperature is important as well. You want to make sure the room is of not normally how it is. You want to make sure it's a little warmer. It's a little different than if it was a basic OR like surgery or things like that, because these babies are small. They can lose a lot of heat to the environment. So you want to make sure that the room is a little warmer than normal. That way they don't lose too much heat. And you want to make sure you get an OR temp for the baby, like a temperature in the OR and a temperature in the admit bed in the NICU, because that's another thing in golden hour. You want to make sure that within the hour you have them with a normal temperature. Next, you want to do a head-to-toe assessment. You want to make sure that the baby doesn't have any sort of lacerations, maybe from the delivery. It could be from when they cut the mom. You never know. So you want to just make sure head to toe that everything looks fairly normal for a small baby. No sacral dimples, things like that. While you're setting up for lines, sometimes they're going to do umbilical. Most of the time they're going to do umbilical lines, and from there they can usually draw labs. But you want to make sure within that hour that you get those labs drawn and that you've sent them to the lab before you've administered antibiotics. You don't want to do a blood culture on a baby that the antibiotics have already been administered, because in a sense then it could be a contaminated specimen because the baby is already being treated. So you want to make sure you do a blood culture prior to administering any antibiotics or any other fluids. That way it's the most clean sample and you can determine if the baby is septic and treat them accordingly. Another thing I want to mention that's different than adults is administering antibiotics ASAP. Usually with adults, you'll do a blood culture, determine the bacteria the patient has, and do a culture and sensitivity for that patient and give them the proper antibiotics to treat the proper bacteria. For us, what you're going to do is treat the baby before you've gotten the results of the blood culture with broad spectrum antibiotics, usually ampicillin and gentamicin. You could swap out the gentamicin for something else, because that is very, it could be autotoxic for these babies, especially the ones that are really, really small. So you want to make sure that they're treated with antibiotics prior to knowing the result of the blood culture, because if you wait the 72 hours to get the full result, it's too late. Most of the patients have declined. They don't have an immune system like most adults do. Even if they're immunocompromised, they do have a little something in comparison to a newborn baby that has literally no immune system. So once you've drawn those labs, usually from the umbilical line that the MD has placed, you want to make sure you get a glucose. Because in the hour, you want to make sure that the baby has maintained or has a normal glucose to make sure that it improves their outcomes. When a baby has limited glycogen stores and the glucose is low, it could affect the brain. So another thing that you want to do is make sure that they have IV dextrose. And I've mentioned that already, but that's very important for these babies. They need glucose for the brain. So that's why we check the glucose within the first hour of life. Also, for these extreme prematurity patients, we want to make sure that we don't cause any brain bleeds. They have very friable vessels in the brain and they can have brain bleeds very, very easily. So we want to make sure that once the baby is on their admit bed, that we maintain a supine position without changing their position for at least 3 days. That helps prevent the IVH that normally happens in prematurity patients. It may not prevent it, but it may reduce the size of the IVH. Instead of a grade 4, maybe a grade 2. But that is implemented in most places where you try not to move the patient for the first 72 hours of life. As always, you also want to make sure that once the baby has been stabilized, that the room is set up with an ambu bag and also a code sheet. Those are very important because the baby can decline at any time, and you want to make sure that you have all the necessary measures to make sure that their outcome is improved and that there's no delay in care. I believe that's pretty much it. I know that it's a lot, but it's something to make sure that if you're in a delivery hospital or you're going to be joining a delivering hospital, that you are aware of this. Because even if you're not in a NICU, let's say you're in L&D or mother baby or nursery, it's important to know what a golden hour admission would look like. That way you're not as intimidated, because even if you don't have a NICU, there's most likely going to be a transfer imminent if you're delivering a baby less than 32 weeks. But that way you're aware of what's the best setup for that baby and to have the best outcomes. I hope it wasn't too much information thrown on you too fast, but that's pretty much it for this video, guys. Comment down below if you'd like any more information about golden hour. I'd be happy to help. Please like this video, subscribe if you haven't already, and I'll check you guys in my next video. Bye!